Well, good afternoon. Good morning for any of you who are from California. That was a really nice introduction. I appreciated that. Although it gave away about half my speech, so I'm going to just go through about 50 slides because we've already heard about them. I have been to Kentucky before. I've never been to Bowling Green before. And I went to the downtown square yesterday evening, and I was sure it was the scene of Back to the Future. You know, I was looking for the clock tower. It's a beautiful downtown square if you haven't seen it, but it reminded me of some of the, the beautiful gems that exist in the Midwest that we forget about sometimes, that make life worth living. I'm going to jump right into this. I want to appreciate Susan Zepeda and the Foundation for a Healthier Kentucky for having invited me. I've known Susan for a long time in various different iterations, and she's a strong leader. You've got some wonderful things happening in Kentucky that I think are in no small part due to leadership like hers and others, of those, many of you of whom are in the room. It's kind of amazing to me what Kentucky has done. I come from California, where we get a lot of credit. We set out to be the lead car in the implementation of the Affordable Care Act. We wanted people to say, if California can do it, anybody can do it. But what ended up being the mantra was that if Kentucky can do it, anybody can do it. That's true. You should give yourselves a hand for that. So now California is envious of Kentucky. Just letting you know that. I like to say sometimes when I come from California, I'm from California, therefore I'm from the future. So everything that I'm going to tell you is going to happen to you, just hasn't happened yet. All right, so let's just jump right into this thing. All right, and now I forgot what button to press. There we go. Okay, so the fun of this work is to really try to understand sort of big macro phenomena. We spend a lot of time in health and healthcare trying to understand micro phenomena, how patients respond to a certain chemical, quite frankly, how their physiology can be altered by giving them a blood pressure medication or a diabetes medication. This is not about that at all. This is really about how populations respond to different types of forces, factors, influences, variables. So it's like microeconomics. You think about microeconomics as, when we had the big crisis, people took out loans that they couldn't afford. Banks made offers to people that they knew they couldn't afford. On the micro level, that caused people to lose their homes. On the macro level, it crashed the world economy. This is a similar conversation. The difference between health and healthcare is really the difference between macro and micro. And place plays a big role in that. So I'm going to talk about that. This is where I grew up. I'm not going to, well, maybe I will. Well, no, I'm not going to ask you. Does anybody know where this is? You already know it's in Canada. It is an island. It's an old volcano in the middle of a river. It gets very cold, and we love hockey there. Somebody want to shout it out? Not Vancouver. Vancouver does not get cold. You do not understand cold until you've lived on the other side of Canada. Quebec, Montreal, Quebec. This is Montreal, Quebec, where I grew up. And Montreal, Quebec is a beautiful city. Like I said, there's a view from a big volcano that's overlooking downtown. You can see the St. Lawrence River in the background, downtown Montreal, and McGill University, where I went to university for free, quite frankly. And this is a picture of my brother and I growing up there, feeling very loved. And I, to this day, feel like that society really invested in me. Like I said, I went to university for free. There's universal health care. There's universal dental care up until the age of 12. Universal child care, deep investments in parks and recreation. There's safe communities. It was a nice place to grow up. A very high level of college education amongst the population up there, and it's very diverse and very cosmopolitan. And then I moved in the mid-1980s from Montreal to Baltimore, Maryland, where I actually happened to have been born, just by coincidence. My father was a graduate student in Baltimore in the 60s. And I went to Johns Hopkins Medical School because I was told it was the best medical school in the world. And at Hopkins, there's actually this mantra that says, we may not be the best, but there's nobody better. So I figured, how could that be a bad place to go? It's got to be great, and it's in a city, and it's a city that my parents loved when they lived there. But this is what I was confronted with when I got to Baltimore. And I had no frame of reference for this. I literally did not know what I was seeing. And I was being driven around by one of the upperclassmen and touring us around, and he saw my jaw agape, and he said, "What's wrong?" And I said, "When was there a war here?" And he looked at me, and I'll never forget what he said, because it actually stimulated my lifelong career. He looked at me and he said, "What do you expect? It's the inner city." And I thought, what do I expect? I should expect this? This should be a norm for me? This should be okay? And you've got a name for it. You've called it the inner city. And you've walled off your problems in that place. And you ignore it. And you know, all of a sudden I could understand the 6 or 8 different American movies you see where some hapless family is on vacation and they take the wrong exit off the freeway and they end up in the inner city. And the rest of the movie is how they're trying to get out. You could not make that movie in Canada. You don't have a place that you could describe in this way, but we have these places all over the United States. And I asked myself, what would it have been like had I been a kid growing up in this place, where the message to me every day is that you don't matter. Every day of the week, I'm being told I'm not valuable. And kids internalize that. You see that in young people. I go back to Hopkins periodically to talk in their Social Determinants of Health Symposium. These were pictures taken in that same neighborhood last year. And this is 30 years later. In fact, there was a study done in Baltimore recently looking at 2 populations of low-income men, primarily, African American and white, and studied them longitudinally over a period of a number of decades. And they concluded at the end of this study, because for the most part, the economic strata that these young people were born into in Baltimore is the economic strata that they ended up living in their entire life. There's no social mobility in this community. Where you start is where you end. And that has profound health implications. And we've seen Baltimore manifest this anger and rage recently. For those of us who've lived in Baltimore, knew Baltimore, this was entirely predictable. And it's not just Baltimore. Not far from here is Scott County, Indiana, which as of recently has over 180 cases of new onset HIV, driven by an epidemic of opioid use, injectable opioid use, primarily prescription drugs. And we see deaths, and we see the demographics of this community are almost entirely white, 97% plus white, and they have an HIV rate that's approaching sub-Saharan Africa in some instances. And you have to ask yourself the question, between Baltimore, Scott County, what's happening in these places? What kind of opportunity structures exist for people that they're making these kinds of choices? In fact, I like to say to people, I could make any of you a smoker or a drug addict, quite frankly. All I would have to do is start taking things away from you. Take away your housing, take away your education, take away your social relationships. Stress incubates in these places where people feel they have no opportunities, and it manifests themselves in different ways. We end up treating the symptoms of that, but we rarely go underneath to try to understand what's driving it. So the question for me that led me on this journey was, does your zip code matter more than your genetic code when it comes to your health? And if it does, what is it that we ought to be doing to try to change that? Okay, so I ended up in the San Francisco Bay Area after medical school and to go to law school. This is the San Francisco Bay Area, for those of you who don't know it. That's California. This is San Francisco. And this is Alameda County, where I became the health officer and subsequently the health director. Alameda County is shaped like a big boot that's trying to crush San Francisco. And we think about it all the time, believe me. And so when you become a health officer, one of the great things that you can do, which is fun, and I'd love to do it for Kentucky, quite frankly, because it's really easy to do. Maybe it's been done already. I haven't seen it, but I'd love to see it, is you can take death certificates. You're the guardian of all births and deaths, all records of births and deaths. You're the recorder of those things so that you actually can get very good data on deaths. And on a death certificate, you can tell what somebody died of, how old they were when they died, what their race, ethnicity was, and where they lived. And you can use that information to construct a fairly interesting profile of death in a community. One of the things you can do is you can look at life expectancy over time. When I got to Alameda County, I didn't know what my job was, quite frankly. So one of the first things I did was I looked at Healthy People 2000 and Healthy People 2010, and Healthy People 2010 said the first goal was to increase life expectancy for all populations. The second goal was to eliminate health disparities amongst various different groups of people. And so I thought, okay, well, I can do that. So I went to my epidemiologist and I said, where are we on life expectancy? And they said, I don't know. And I said, well, shouldn't we measure it? And they're like, why? And I said, well, it's the #1 goal of Healthy People 2010. It's the first one. And they're like, okay. And so we measured it. And to do this, it's actually very easy to do, and because we had all these death records, we had about 500,000 death records in Alameda County dating back about 55 years. And so we went back as far in time as we could, and we wanted to look at life expectancy in different populations. And if you want to go back before 1990, really, you can only talk about white, black, and other. So this slide only shows white and black. It's only post-1990 that the census, because you need the census to do this, started talking about other racial groups. Well, one of the first things we noticed that in 1960, life expectancy difference between blacks and whites was about 2 years. In fact, in the mid-50s, there was some nasty flood in Alameda County in the recorder's office, and they lost a whole bunch of death certificates. But in the early 1950s, the life expectancy difference between blacks and whites was actually the same. In fact, African Americans lived a little bit longer than whites in Alameda County in the early 1950s, and then it grew to about 2.3 years in 1960. 20 years later, it had more than doubled to about 5 years, and then 45 years later, it was almost 8 years. And our explanations for this are not good. When I say ours, I mean public health in general, because this is during a time of an explosion in health technology, MRI, CT scans, minimally invasive surgery, all kinds of new technology was coming to bear, and the dominant narrative was that this technology was going to save us. Meanwhile, during this period of time, we see a widening of health disparities, a primary health disparity and a health status measure that is universally comparable to other countries during this period of time. And, I used to say that if we were really held accountable to the things in Healthy People, I should have been fired during this period because this gap increased on my watch. And again, the #1 goal is to increase life expectancy for all populations. Well, life expectancy is increasing for both of these lines. The African American line is the lower one. But the #2 goal is to eliminate health disparities amongst various groups of people, and on that goal we were clearly failing. Now people said, well, this is because of homicide or because of HIV/AIDS, which was flaring up in the 90s. And so we decided to subtract out homicide and HIV/AIDS, subtract out a combination of homicide and HIV/AIDS, and what we found is that those two diseases actually contributed fairly little to this overall difference. This difference is driven by chronic disease. This is heart disease, this is cancer, this is stroke, these are lower respiratory diseases. This is bread and butter public health, the stuff that we ostensibly know how to prevent and certainly how to treat. That was a good clue for us because we thought this may be something very different. No, this is chronic disease, and whenever you see this anywhere in the country, it is driven by chronic disease. So you can also take the death certificate, and you can actually take the boot, which is Alameda County, and map every census tract and calculate the average age to which people will live in any neighborhood. There are about 150 census tracts in Alameda County, about 10,000 people in each one, and the ones that are in green are where people on average live above 80 years. The ones that are in red are where people on average live less than 74 years, and the yellow is in between 74 and 80 years. And we saw immediately that these neighborhoods with low life expectancy in Alameda County tended to cluster. In this particular instance, in the so-called Oakland Flatlands and part of the Berkeley Flatlands. And when I used to show this map around the country, quite frankly, people always just come up to me afterwards, and this is why my slideshows get so big, because people come up and ask me questions and I have to make a slide about it. People would come up and say, I don't want to live in Alameda County, sounds like a horrible place. And I was like, wow, you're totally getting the wrong message here. So we had to go to some other places, like this is Cuyahoga County, Cleveland. This is Baltimore, Maryland. This is Los Angeles. This is Seattle, King County. This is New York City. This is Philadelphia. This is Minneapolis, St. Paul. Everywhere we have looked and helped people do this simple analysis, we find dramatic disparities, and on the order of 25, 30 years in the same city. 25 or 30 years. This is something that the Robert Wood Johnson Foundation did, which I thought was quite clever. They predicted how long you live based on what stop you get off on the commuter train. So the other thing that you can do, if you're a data nerd like me, I proclaim it, I'm a nerd, is you can take life expectancy and poverty and you can correlate them. You've got a life expectancy number for every census tract and a poverty level for every census tract, so you can do what's called a simple bivariate correlation. Life expectancy is on the up axis, or the y, and the poverty rate is on the x-axis, or the lower one. And as you go from left to right in this graphic, you're going from relatively wealthy neighborhoods to relatively poor neighborhoods. And in an ideal world, this would be a completely flat line. Where you live shouldn't predict how long you live, but it does. We don't live in an ideal world. And there's a cost to living in a poor neighborhood that you can actually measure, you can calculate, you can predict based on this association. So we have people living, each of these blue dots is a neighborhood, people living in Alameda County neighborhoods that live on average above 85 years, people living in Alameda County neighborhoods that live in the mid-60s. If you look at the world life expectancy map, you're talking about some of the highest life expectancy countries in the world, so Japan, Sweden, Hong Kong, as well as some pretty mid-level developing countries like North Korea, Nepal, Kazakhstan. So we have the socio-ecological equivalent of Kazakhstan and Sweden, all in Alameda County. We did the same analysis for the entire Bay Area. This is 6.5 million people. Same analysis for the entire state of California, approaching 40 million people. In the Bay Area, because part of our job is to communicate this to non-public health people, we monetize the slope of that line. We wanted to create news. So what we said was that every additional $12,500 in household income in the San Francisco Bay Area buys you a year of life. That's the cost of life in the San Francisco Bay Area. And so I encouraged people to use that number when they were negotiating their raises. Because quite frankly, can you imagine the conversation, hey boss, I've been working hard, I've been making those reports, I'm thinking I need 2 years of life expectancy this year. And the boss saying, Tony, I don't know, you were late on that Johnson report and, some of your work has a lot of typos in it. I'm seeing 6 months for you, tops. So I won't ask who the epidemiologists are in the room because there probably are some. And I can probably guess because you were squirming for the past 5 minutes or so, because I was showing you data that is a correlation. It is an association between two variables. It does not prove cause and effect. However, you can stop squirming now because I also have longitudinal cohort data, which is the best quality data that you can get on this particular question. And it happens in Alameda County. We have an ongoing longitudinal cohort study, 7,000 Alameda County residents that have been followed since 1965. This cohort study has produced over 200 papers, amongst which is one that shows that if you have a household income 1 standard deviation above the mean, you're 25% less likely to die prematurely. If you're 1 standard deviation below the mean, you're 35% more likely to die prematurely, which is almost an exact fit with our regression line, that slope that I showed you earlier. So we're very confident that this data is real. Where you live predicts how long you live. Okay, so American health is not that great. Despite the fact that we like to think that we're number one, we're not even close. We're not in the top 10, top 20, not in the top 30. So this is a study that came out in 2005 in the New England Journal of Medicine, which is one of my favorite studies because it is the battle of two different groups of nerds. It's a group of nerds at the CDC and a group of nerds at the Social Security Administration. And so the CDC, this is like a kind of a dance battle. This is the way that nerds do dance battles. So the CDC kind of threw down in the New England Journal and said, the nerds at the Social Security Administration have it wrong. Based on the data that we're seeing on chronic disease, primarily obesity, diabetes, we are anticipating that life expectancy in the United States will soon begin to plateau and then decline. And therefore, the Social Security Trust Fund is actually more solvent than the Social Security actuaries are saying it is. Because people are going to die, and that saves the government money. So this was a prediction in 2005 in the New England Journal. A couple of years later, a group at the University of Washington actually calculated life expectancy for all of the 3,000 counties in the United States and found for the first time plateauing and decline, particularly in the southeastern United States and the Mississippi Delta, particularly amongst women. And this was shocking. They noted that between 2000 and 2007, more than 80% of US counties, so that's about 2,400 counties out of 3,000, fell in standing against the average of the 10 nations with the best life expectancies in the world, sometimes referred to as the international frontier. A colleague of mine at Stanford shortly thereafter did almost the same analysis, although he used a different measure of mortality that allowed him to control for some of the input variables, namely income and education. And what he noted is that when you control for income and education, all of the differences in life expectancy across the United States at the county level disappear. They don't exist. You can explain this entire variation based on differences in income and education, which are socially mediated variables. These are not genetics. This is not God from on high saying that the people of the Mississippi Delta have been living too long, let's shorten it up. This is about income and education and differences in those variables, exclusively. More recently, there's been some really kind of interesting and horrifying data, in a sense, looking at life expectancy differences and how they're widening, and in some cases they look like they're widening beyond the point where you can actually close those gaps. And this is particularly for white women in the United States, particularly in low educational attainment segments. And this is what this graphic is showing on the far left here. You see 1990 in blue, 2000 in green, and 2008 in red. And these are women with less than 12 years of education that are white, and we're seeing a pretty precipitous drop in life expectancy. And people don't know what's causing this, and we're trying to figure that out. This is some interesting data. You guys have seen this all before. The US spends way more on healthcare than everybody else. I mean, our expenditure level is twice the average of all of the so-called developed countries, the OECD countries. And when you look at that, based on the level of spending we have, are we still working here? There we go. If you predict based on our level of spending, you would expect us to be much higher in life expectancy. If this graphic made sense, we're in fact actually way below where we should be based on the amount of money that we spend. Well, this woman at Harvard by the name of Elizabeth Bradley did this very interesting study. Started from actually an op-ed that they wrote in the New York Times, which talked about the fact that it's really not health spending that drives health. It's actually social services spending that drives health and investments in social benefits. And so what they did is they measured social service investments across all of these same OECD countries, these developed countries, and they added it to healthcare expenditures. And when you do that, you find that the US is not an outlier. we actually spend kind of in the middle range between health and social services of other developed countries. Yet what we get health-wise from that is much worse because our ratio of health spending to social services spending is actually inverted. Most of the developed countries in the world that actually have good health outcomes spend about twice what they spend on health on social services. We spend the opposite. So our accent is on the wrong syllable. We actually spend not too much money, we just spend our money badly. And that this study that Bradley did is turned into a book now, noted that the ratio of social to health spending was significantly associated with better health outcomes, including less infant mortality, less low birth weight, premature death, longer life expectancy, and this even remained true when you took the US out of the analysis. This is some other interesting data that I really like because it really just answers the question. One of the things that's hard to understand is that does more spending mean more health? And as you can see from Bradley's effort, it depends on the type of spending. But when you just look at health spending and you look at life expectancy, you see that it's kind of a jumbled picture. These are, again, rich countries, and this is their per capita spending on health. And on the up axis, the y-axis, is life expectancy. So Japan is up there at the top. So do I have a pointer? Yes, there's Japan. And the US is kind of down by the bottom, but way over here on high per capita expenditures. So they didn't understand. They said there's no pattern to this. You can't fit a regression line to this. There's no way to try to explain this. So they changed this variable on the bottom, the per capita spending, to measures of income inequality. In other words, how is that money distributed in society? And all of a sudden they saw a pattern, that those with high levels of income inequality had lower levels of life expectancy. Those with low levels of income inequality had higher life expectancy. So it's not how much money you spend, it's how that money is distributed in the society that actually correlates with life expectancy. And they went on to do this with the 50 US states. And there's, where's Kentucky? Kentucky is, there we go. Is that it? Yeah. There's Kentucky. So this is on an income per person basis. So relatively low income per person, relatively high levels of this. They used an index of health and social problems. So basically kind of sick and kind of poor. And then they reassorted those states now by levels of income inequality. And where's Kentucky? There's Kentucky. High income inequality, high level of health and social problems. So this is just the data talking. This is not political. There's nobody here running for office. This is just numbers talking to us, trying to tell us something that we should use to inform policy. Okay, so I told you I make slides when people ask me questions. I used to get this question all the time, kind of like, well, the US is so exceptional, we're so different, we're so diverse. And isn't it just our diversity that kind of drags down our numbers? And I thought, okay, I need to make a slide. And so this is just looking at non-diverse America. This is just life expectancy of white Americans. The most recent data suggests that US white life expectancy is about 79 years, which is equivalent to of Qatar, Costa Rica, and Nauru. I had to look up Nauru. Nauru is a Pacific island, very small Pacific island. It's actually shorter than Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, Netherlands, Portugal, the UK, Canada, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, I still don't know where that is, Australia, Italy, San Marino, no idea where that is, Singapore, Spain, Switzerland, Japan. There are 33 countries in the world that have longer life expectancy than white Americans. In 1990, there were only 17 countries that had longer life expectancy than white Americans. So it's not just our diversity that's making us sick. There's something bigger, something that we need to understand, because we're wasting a lot of money on health care, not getting a good result, and we keep pushing in the healthcare direction as if that's going to solve our problems. Now, one of the definitions of insanity is continuing to do the same thing over and over again and expecting different results. So you could argue that our health policy is insane. I just did. It's insane. Okay, this report came out from the August Institute of Medicine fairly recently, and for those of you who've ever participated in an Institute of Medicine panel, it's painstaking, it's exhausting, they're very detailed, they make recommendations to Congress, they call witnesses. So this is a report called Shorter Lives, Poorer Health, which you can tell already is not going to be a good outcome. This is comparing the US to 17 other peer countries. This was the conclusion. And the IOM doesn't get emotional. This is as emotional as it gets. And this is basically them screaming, our hair's on fire, oh my God, what is happening? The panel was struck by the gravity of its findings. A panel struck by the gravity of its findings. So just picture that, kind of like, holy shizzle. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. The US health disadvantage cannot be fully explained by the health disparities that exist among people who are uninsured or poor, as important as these issues are. Several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. This is across the board. So I work at an organization called the California Endowment, which is a health foundation, which I love. It's a great job. They hired me and they said, here's what we want you to do, Tony. Here's a piece of paper and $1 billion. Your job is to measurably improve the health status of people in 14 low-income communities throughout the state of California over the next decade. And the only caveat is you cannot spend a nickel on health care. So $1 billion, 10 years, 14 low-income communities that are contending with significant health disparities, measurably improve the health status of those populations. So one of the things we're trying to do is change the narrative about what produces health. And so we've created this campaign, which is basically a split image campaign showing real life expectancies in real places, real high school graduation rates, which we think is the single most important modifiable education in general, social determinant of health, in real places. This is the new Sacramento airport terminal where all the legislators fly through, so we decided we would have a conversation with them with our billboards. We know that they saw these because I started getting calls asking why I was decreasing property values in their districts. This was the Metreon building in San Francisco at APHA a few years ago, where we literally festooned the entire building with these images. This was the governor's office about a year ago, where the governor was nice enough to let us advertise outside of his office for about 6 months. I have no idea why he let us do that. So you may have grown up in a place that looks like this. I actually did. I grew up in a very nice neighborhood in Canada, although we were very middle class. Or you may have grown up in a place that looks like this. I went to medical school in a place like that and saw and treated young people who grew up in that environment. You may have shopped in a place that looks like this, or this may be your grocery store. And the question is, what does that do to your health? Well, one of the things we know is that 80% of what influences your life expectancy happens outside of the healthcare system. In fact, it's probably closer to 90%, quite honestly. In 1993, 2 sort of pillars of public health practice, Bill McGinnis and Fahey, published this article in JAMA called The Actual Causes of Death, and they said we have to stop talking about diseases. We have to get down underneath diseases and understand what the actual causes are. And they said there were 4 causes. One was the environment, another was healthcare, then biology or genes, and then lifestyle. In healthcare, they gave only about 10% essentially contribution to improving health status in populations. Since 1993, we've learned that this is even too simple, that the environment actually changes your genes, the phenomenon of epigenetics, which is basically simply explained if I take two identical twins and I put them in radically different environments, their genes will express themselves differently as a result of those environments. But that's actually not the most interesting part of this. It's really, does the environment shape our behaviors? Because behaviors shape chronic disease so profoundly. And we've spent so much time with trying to change behaviors by giving people brochures. And in those brochures, it says things like, hey, you know what? You should probably not smoke. Or you should wear a seatbelt when you're driving in your car. Or, hey, if there's bullets flying, duck appropriately. And then we sort of wipe our hands and we say, hey, we've done our public health job, and we get paid by the number of brochures or encounters we have with eligible individuals. And I don't have to tell you, every health department I've been to has a room that's entirely dedicated to brochures. Some of them are 30 years old. And you open the door and you get knocked over by all of these brochures, because that's how we get paid in public health. I mean, that's literally what happens. It's like, how many brochures did you give out? We gave out 100 brochures at the health fair. Yay, you get paid. But we know that it's more complicated than this. And this is really about this whole notion of allostasis or chronic stress. I'm not going to spend a lot of time on this slide because none of you wants to go back to medical school or to medical school if you didn't. I'm going to simplify this for you. Allostatic load or allostasis is basically how the body maintains kind of balance in the face of different challenges. And allostatic load is sort of wear and tear on the body over time when the body's stress responses are turned on kind of constantly. And those stress responses are driven by stressors. And we all have stress. There's nobody in this room that has not experienced stress at this minute. You're experiencing stress. Some kind of, probably because I'm telling you things and you're like, this guy's full of shizzle. But everybody experiences stress. As my friend David Williams likes to say, the person who's not experiencing stress is dead. So these stressors may manifest themselves as inadequate transportation options, long commutes, inadequate housing that's not affordable, poor quality, being socially isolated and not having social capital, experiencing racism or other forms of discrimination, having high demand, low control jobs. A lot of people in public health say they have those. A lack of access to stores or necessary health amenities, or crime. All of these things are being interpreted by your body at all times. We take these stressors in through our brains, primarily through the hypothalamus, which stimulates the pituitary gland, which stimulates our adrenal glands, which sit right next to the kidneys, which release a cascade of hormones, amongst which is cortisol. In the short term, in acute stress, cortisol is good for you. It increases your cardiac output. It increases the available glucose that your muscles need if they're going to run or if they're going to resist. It enhances your immune functions. It turns down inflammation. And it stimulates growth in the hippocampus and prefrontal cortex parts of the brain, which are really necessary to make what's called to conduct executive function. Executive function is the ability to choose from a wide variety of options, some short-term, some long-term, some intermediate-term, and pick the best choice for that moment. And that's good. But in red, when you're constantly exposed to stressors, you're living in a community where you're in fear, where you don't have access to resources that you need, and you're basically living in a constant fog of stress. What that does to your body is almost the opposite of what it does in the acute period. It causes hypertension and cardiovascular disease. It stimulates glucose intolerance and insulin resistance. It, by the way, also makes donuts look much more appealing. Cigarettes look much more appealing. It stimulates inflammation, turns down your immune system, and it actually causes atrophy and cell death in the same neurons that I described to you as being necessary for executive function. There's more recent, I don't want to get too technical, but there's more recent data that show that actually allostatic load actually changes your chromosomes through action on these so-called telomeres. Telomeres are like, it's kind of like the end caps on your shoelaces. Telomeres, the long telomeres are associated with long life of the cell. Short telomeres are associated with cell death. And these are, so the blue area there is sort of what telomeres look like. There's studies now that suggest that telomeres are actually shortened in contexts where people are living in acute stress, including in neighborhoods where people are systematically deprived of resources that they need in order to be healthy. Okay, so what does it mean to lose control? To really have things happening to you and to have the absence of what we call agency, the ability to essentially use the resources you have at your disposal to navigate an environment that's fraught with risk. Our argument is that when you look at health disparities, you're only seeing the tip of the iceberg, and our strategies in public health and our practices need to look underneath the surface of the water. I want to show a quick video, if my able colleague here can pull it up. I'll tell you about this in a minute.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in Beeville, around 4 miles away. They're similar in so many ways, but here's the thing. On average, residents of Beeville will die 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb's and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventative health care. On the other hand, Beeville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhaust from the nearby highway. And for food options, Maria's only choices are Beeville's many liquor stores, fast food places, or convenience stores. The schools in Beeville are overcrowded and undersupported. Yet even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, not having the same healthy options as A-Town can be overwhelming, a constant source of stress and a health issue. In fact, for all the residents of Beeville, it drives health problems like obesity, diabetes, asthma, and heart disease. And how did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, it began with racial discrimination. Over the generations, poor people and people of color were pushed to less desirable parts of town. In those neighborhoods, banks refused to lend money. Businesses left, jobs too. Schools declined, and the neighborhood crumbled. Everyone who could move away did. And here's the thing. When communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, or upper income, die younger than their peers in other countries. In fact, our life expectancy is 42nd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality. Inequality hurts us all. So what do we do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow, we lead. We are making health happen in communities across the state. We are coming together to build one California. A smarter, healthier, and more equitable state that creates opportunity for all of us. Join us. To learn more, visit calendow.org/buildinghealthycommunities.
Okay, thank you. So, in that, we talked about Maria having to juggle all of these various different options. And I'd like to help people understand this by thinking about yourself. If I give you a tennis ball and I say juggle it, you're like, ha, 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 you can juggle a tennis ball. Then I toss you a second one, you're like, hey, I can do two. Then I toss you a third one, and probably a third of you can actually keep them all up in the air. I give you 4, 5 balls, you're all dropping balls. In these communities where people are struggling to find healthcare, housing, safe parks and places to play, decent food, decent jobs, good schools, they're having to juggle 8, 9, 10 balls simultaneously, and of course they're going to drop balls. And when you start dropping balls regularly, you basically start to tune out. You start to give up. And that's when chronic stress starts to manifest itself most effectively throughout your physiology. And that's what's happening. We're creating environments where people are forced to juggle too many balls. And this is across various different groups across the United States. It's not just in low-income communities. And these things are driven by policy. So what we've tried to do is create a framework to try to understand this. The traditional framework is basically the medical model, which basically says that when you look at premature death, it's driven by high burdens of disease and injury, which is driven by risk. Risk primarily in 2 forms, risk being risk behaviors, and then risk factors, things that you have, like if your genetics are in a certain way, or you just have a particular complement of diseases that lead you to be sicker than others. And we think of the variables we have at our disposals to change that are genetics, brochures, and healthcare access. And that's the medical model. I used to joke with people, I said, that's what I learned. I paid $100,000 to go to Johns Hopkins Medical School. I just gave you a Johns Hopkins Medical School education for free in 5 seconds. This is basically what we thought this is the world of levers we had at our disposal, and our goal was essentially to intervene in individual health and behavior to try to change their individual health trajectory. And the truth is, we spend about $3 trillion a year in the United States in this model. And it actually is true. It works. It works. But it's insufficient, because this is really dealing with symptoms. This is really dealing with the downstream consequences of inequity. And so we've expanded the model. This comes from a group called the Bay Area Regional Health Inequities Initiative, or BARHI. And it's basically a framework that just tries to explain where do we have other opportunities to intervene that we are missing and that we should be developing a practice for. So it argues that downstream you see the manifestations of health disparities, upstream you see the manifestations of health inequities. And you can take health out of this equation and just talk about inequities producing disparities. Or if you're simple-minded like me, you talk about conditions producing consequences. And we spend $3 trillion a year in consequence management, or I like to refer to it as damage control. And the argument is, what can we do upstream while still working downstream? You know, I remind people all the time that you walk into a community and there are fires burning all over the place, what's the first thing you do? You grab a hose and you put out the fires. And then if it's a Budweiser commercial, you high-five your buddies, you go to the local bar, you drink a pint, you go home, you sleep, you get up the next day, you come back to the community, and there are fires burning in exactly the same places. Now what do? Well, now you grab a hose and you put out the fires. But probably you don't high-five your buddies and go to the bar. You're thinking, that was weird. There are fires 2 days in a row in the same place. And you go home, you go to sleep, you get up early, you come back next, fires in the same places. You grab a hose, you're putting out the fires, and you're saying, okay, what's causing these fires? And that's what this argument is, that you have to look at those conditions to figure out what's producing this burden of disease. And then you have to do more than just look at the conditions and put them into a journal that sits in a library. You actually have to develop a practice to try to address those conditions. And that's what we're trying to do. We argue that it's not just health consequences downstream. You can look at educational consequences, as I mentioned before. I think education is the single most important social determinant of health because it's amenable to modification. There isn't a constituency that is arrayed against education. I mean, there may be some that want to privatize it, there may be some that don't want to spend so much money, but there isn't anybody who will stand up and say, I don't think our people should be educated. At least if they are, they're not getting a lot of traction. So we're arguing less focus on downstream, more focus on upstream. We've simplified upstream into a practice we call place, policy, and narrative. We think there's a critical, important piece here, and this is why I say health is political, because it requires power. And one definition of politics is it's the struggle over the allocation of scarce and precious social goods. And communities that are not participating in that conversation tend to get an inequitable distribution of those goods. And so part of the practice needs to be building participatory democracy, getting people to participate in decision making. And when I talk about scarce and precious social goods, I'm talking about things like a grocery store or a park. We're not talking about a Rolls Royce. We're talking about basic community amenities that we know all communities need in order to have a greater likelihood to be healthy, especially children. So the medical model says bad behavior produces disease, produces premature death. The socio-ecological model says that bad societal behaviors, which is really about a narrative about who matters and who doesn't matter. When you look at East Baltimore or South Side of Chicago, or even some of our Scott County, Indiana kind of communities, those communities have been disinvested in. And because those communities are perceived as being less powerful, less important. And there's a narrative that historically was based on discrimination by race, by class, by immigration status, by gender, by disability status, that produces policies and practices that create conditions in communities that leaves them on life support. And then when we put big, important medical institutions in these communities, and people come into the doors of those communities, we hand them brochures and tell them not to smoke. That's basically our practice. And we're smarter than that. We're way smarter than this. The data has told us a lot more than this practice would suggest, so we need a real practice that addresses these issues. We have a practice to prevent death, we call it emergency rooms. We have a practice to try to reduce disease, we call that clinical care. We have a practice to try to change behaviors. I joke that it's pamphlets and brochures, but it's really health education. Some of it is very creative. We don't really have a practice to address communities that are on life support. And if you want to change health outcomes, you have to change this. This is where other developed countries have got it right. They recognize that there's investments, social investments that you need to make for the betterment of everybody that actually reduce health care costs. We call our practice building power in place because we want people to participate in shaping how amenities are distributed across communities. We think that's not sufficient. You also have to change policies. You have to look for health in all policies, and you have to actually look at the health consequences of non-health policies and actually use data differently. You have to map it, show people how it overlaps, how it manifests itself in communities, not just charts and tables. You have to be able to make it relevant to policymakers, decision makers, and media. We think that that's not sufficient either. You also have to change the narrative about what produces health. Health is not just health care, and the people who are most impacted by this need to be able to speak to the conditions that they're facing themselves. So very quickly, I just want to talk about what we're doing, what I'm doing with this $1 billion in 10 years in 14 places. We call it Building Healthy Communities, and it's an ecological approach to improving health. I was very fortunate that our board decided that they would give us 10 years to do this. I don't want to intimidate anybody, but 10 years is not enough. These problems really have been ingrained for multiple decades, but you can actually make measurable difference in 10 years. We like to think that health happens in communities. It doesn't happen in the doctor's office. These are those 14 places that span the state of California. The greatest resource we have at our disposal is not people in white coats with stethoscopes around their necks or people with lots of degrees behind their names. It's the people who actually live in those communities. The only way that this changes is if people who are actually experiencing these conditions start to participate more actively in reshaping those conditions. The goal of this work, as the video showed, is not to help people beat the odds, it's to actually change the odds. We set the odds through policy. And these odds are entirely amenable to being reset. Different people get dealt different hands. And this is the point that we're trying to make. But there's a dealer in this. And we have to understand how that dealing operates. So the core content of our work, we brought people together to talk about how it should happen. They basically agreed with us that there were three primary environments that matter: the schools, the neighborhoods, and then the so-called prevention system, which is really healthcare and social services. If you want to improve a community, optimize how these three environments operate. That's what changing the odds means. These things shape the life and health trajectories of populations. They're much more potent on low-income populations, but they impact all of us. Don't spend too much time on this, but this is what we call the transformative 12. These are the policy domains. We think that in every community across the United States, if you can optimize the health protectiveness of these policies, you will have healthy communities. The how, these are the key systems: health, human services, including criminal justice, schools, and the built environment, and bringing people together in what we call a hub, which is basically a table where the butcher, the baker, and the candlestick maker come together to make a meal. Very simply, you have to build social, political, and economic power. And what that means is you have to organize people. And it's very doable. It's extremely doable. A lot of us don't think about it because we assume that democracy happens magically, in other places. But it doesn't. It happens when you actually get people to participate. And we live in a democracy, and we get better decisions when more people participate in that decision making. That's not sufficient. You also have to build these tables where people can collaborate. And by the way, I won't take a poll, but how many times have you been invited to a meeting about a grant opportunity that came from the federal government or the state, where they bring together people from different disciplines? And everybody's gung-ho at that first meeting. We're going to work together. We're going to solve these problems. We're going to hold hands. We're going to sing Kumbaya. And then the second meeting comes, and it's the deputies that are all there. Kind of like, oh, my boss told me I had to be here because we're going to work together. Then the third meeting comes, and it's the associate deputies that's there now. Kind of like, I'm here because somebody put it on my calendar. I'm not sure why I'm here. But don't ask me to make any decisions. I can't make any decisions. And then by the third meeting, they divvy up the pot. This much goes to health, this much goes to law enforcement, this much goes to education, and then there's no fourth meeting. And that's collaboration. Well, no, that is not collaboration. Real collaboration is hard. And real collaboration is about forging human relationships. It's about bringing people together so that they can trust each other to do things together. And that just takes time. We do not do collaboration well at all. We're siloed within silos. And that in silos, who prospers in silos? People with a lot of degrees behind their names, the experts. And we love being experts. But that is not how communities prosper. Communities prosper when communities are the expert, when people who live in those communities, who are experiencing those conditions, are driving the agenda, not when people like me are telling people what to do. Beyond that, we need to leverage private capital. One of the things we were able to do, we recognize that there are food deserts throughout these 14 places in California. We put together a fresh food financing fund. We put $30 million on the table and invited all players to come join this fund. Within 18 months, we had $300 million from Bank of America, from Citibank, from Kaiser, from various different actors. And I learned a lesson, because I never would have guessed this would have worked. I thought it was the stupidest idea in the world. The lesson I learned is that money loves money, and that nobody wants to be the first one in. Everybody wants to be the second one in. I don't know why that is. That's the way private capital works. So we raise 10 times our money, and that money is devoted to building grocery stores in low-income communities throughout California. It's about $100 million more than we thought we would need to build the grocery stores in our 14 places, and it's being deployed today. That's critical. Private capital is kind of agnostic too. They're like, as long as I get a return, I don't care what you do with my money. You also have partners like the Federal Reserve, who directs banks to invest according to the Community Reinvestment Act. So we have partners and opportunities there. And then finally, you got to change the narrative. This is what we think is the recipe for building healthy communities. It's about power, it's about policy, and it's about narrative. With that, I will stop and appreciate the invitation here to Kentucky. And I know there's great work happening here, and I know that there are great leaders here. This work requires leadership, and it's doable. So thank you very much.
Wonderful presentation.
Thank you.
I think you can exit if you'd like. A round of applause for Dr. Iton. We appreciate you having the numbers speak to us in a way that we could understand and distilling that information, academic as it was, into very thought-provoking and tangible ideas for the rest of us. Good afternoon, everyone. I'm Renee Shaw with Kentucky Educational Television. I'm glad to be here with you all. I hope you've enjoyed the day so far. A round of applause if you have. And a big congratulations to the Foundation for a Healthy Kentucky for all that they do. We're grateful, KET is, to the foundation and the information and expertise that they provide. It's a partnership at KET that we value immensely. As a statewide media network, we are uniquely positioned to look at how health issues impact the whole state, and it's a role that we take very seriously. I'd like to also acknowledge one of my colleagues in the room, Julie Schmidt, who is here with us today. Our senior health producer, Laura Kruger, helps produce a lot of the programs on our health programs that you see at KET, and we're glad that they have that partnership with us as well. For those of you who are not familiar with our programming at KET, we produce a program that's called Health 360. It's a studio talk show that looks at a complex issue of health from 3 different perspectives in 60 minutes, hence its name, Health 360. We also produce short health segments that are released online and on the air, and our hour-long documentaries. This year, I think we perhaps, Julie and I might agree, produced one of the best documentaries in our health series that we've had so far, and it was called What Does Every Teen Need?, which looks at teen mental health issues and the need for positive youth development and prevention. This is our 6th, or that marked our 6th hour-long documentary funded by the Foundation for a Healthy Kentucky. These documentaries take a deep dive into some very complex issues. With each year, we're delighted that we can grow our library of media resources, and it's an archive that is free to all people in the state and all across the nation. And all of our programs are available to watch online at ket.org/health, or you can look on our KET YouTube channel. We know that people who are helping to make Kentucky a healthier place are the people who are in this room today, you all. We want to help support you by telling your stories, lifting up models that are working, connecting your work to our audiences, and helping connect you all to each other. We are inspired and informed by the work that you do every day, and we applaud you for that. At this time, I'd like to prepare to show you a 6-minute video that's part of a segment we're doing that's coming up in October. This is part of our Health 360 series, and this is going to be on smoking. We have an exciting panel of experts, including Dr. Stephanie Mayfield, who is the Commissioner of Public Health in Kentucky. We have some folks from the Chamber and others who will be joining us. And we look at the latest research on the impact of smoking on our health and on our economy. And we'll also talk about the CDC recommendations for reducing smoking, youth smoking prevention, and the latest strategies in tobacco cessation. So we hope you'll join us. This 6-minute clip that you're about to see is about an effort in Magoffin County to paint a tobacco barn with a 1-800-QUIT-NOW number. Now that's interesting, isn't it?
This property has been in my family. I'm the 3rd generation. Its history is raising tobacco. My grandparents raised it, my father helped, and now it's me. The last time tobacco was raised here was 12 years ago. I remember my grandpa going to the barn and picking, when it was hanging, drying out, seasoning, he would pick it and chew it and test it to see if it's ready to start stripping.
Well, at one time it was a big cash crop. They were almost families grow tobacco, and they lived from their tobacco year to year.
Families were together. I mean, they worked together They was able to socialize together, so it was a family event, you might say. I do Cooper Clayton smoking cessation classes here at the health department. We offer a 12-week step-down program. The prevalence of smoking in this community is very high. It is culturally accepted. A lot of parents feel like, smoking is not as bad as drug use or not as bad as alcohol. And even I've heard of parents buying cigarettes for their kids.
Smoking on this community has took its toll. I've lost a lot of people I know to smoking, to lung cancer.
My dad smoked for 30 years and had a massive heart attack 6 months after he retired. He wasn't deceased at that time, but expecting his way of life, his quality of life for the next 20 years. And it's the number one cause of heart and lung disease in Eastern Kentucky. It's just been a bad cause and effect of good and bad with making money to poor health.
The idea came about with the Tobacco Prevention and Cessation Program. Sent out an email about providing grants. And then one of the options was doing the 1-800-QUIT now on a barn, on a well-traveled road. And that just intrigued me. And then it was different. I think sometimes you need to do something different to awaken people up. As soon as I read that, I thought, Mountain Parkway, East Mountain Parkway, what better corridor that people travel through? I think over 10,000 people a day travel Mountain Parkway. So I told my supervisor, I said, I've got a project I'm going to go work on.
I thought it was kind of ironic to quit smoking on the tobacco barn. It's kind of weird, but the funding was there, and as a director and is in my department, we was going to be one of the first ones in the state to get to do the project. I was excited about it.
The old advertisements for the barns, they all had the same lettering, they all had the same coloring, they all had the same basic advertising, simple. And I think as far as I've done billboards and different things, and the newspaper articles, a lot of times you have to do simple. People don't want to read a lot. You need to do simple, straight to the point. That way you catch people's eye.
I was approached by the health department, like, you need to put that on my barn. And I'm like, what? And they said it'd be perfect place, off the Mountain Parkway, and they told me what it would symbolize. And I said, okay, sure. I said it maybe help, the community.
The process of getting the barn painted, I'm from Godson, and I want to promote Godson. I've always wanted to promote Godson and work diligently with different organizations to promote Godson and bring things in here. So I thought, I want to stay local. So we had a lady that, her name's Kelly Hatfield. She does some murals in town. So I drove around and looked at the murals, and I thought, I think this could work.
Whenever I was first asked to do the barn mural project, I was a little nervous because it's a lot larger of a scale than anything that I have completed before, but I was up for the job.
When there was a payment, I had people going up and I said, how many letters we got on it, and when are we going to get it done? That's what we're skating on today.
I had so many phone calls and texts wanting to know, what is that? They're painting on your barn.
And I'm like, well, you're going to have to wait and see.
I had several people, call and text and wanting to call that number.
To me, this barn mural symbolizes a change in our education as far as health and tobacco-related illness. Back 50 years ago, whenever all the mill pouch tobacco barns were, everywhere, people didn't understand what that done to their health, and now we have resources available. I think that this being a community effort helped to draw attention, actually, to the barn, because a lot of people that I know personally have approached me and said, I saw your mural. A lot of people that smoke, actually. And I'm thinking, you can't push people into something, but in the future, whenever they're, if they get in that situation where they really want to quit smoking or they really need help, they'll remember that. That'll stand out.
I know it signifies tobacco and everything, but it's history. And I love history. I love preserving. I love mixing history with the future. And I think now that it's more going towards the future. So I'm very, very proud of that.
So that's just one of the many stories that you'll see throughout our series that starts on October the 19th. That's a Monday night at 9 p.m. I hope you'll tune in to KET to see this particular program about smoking, and then log on to our website at ket.org/health to see what other programs we'll be doing in the future. Once again, thanks to the foundation, Dr. Zepeda, for your cooperation and partnership, and we appreciate all you do for all the citizens throughout the state. Thank you.
Thank you very much. KET has been a wonderful partner, and the work that they do, like this and many other programs they produced, as Renee pointed out, lives on their website, and it's there for you to use in your community as a conversation starter. It really is about changing that conversation. Thank you, Renee. Thank you, KET. And thank you for all of you. We are going to take a brief break right now and then wend our way back to the same breakout rooms through the tunnel over back in the hotel. So if it was standing room only at the session you went to this morning and you ducked out and went somewhere else, go on back there now, mix it up, go to a session you didn't go to, and hear our amazing morning speakers and our wonderful Kentucky experts dig deeper on the 4 themes of this conference. Thank you all for being here. Safe journey home when you go home. And please go to those breakout sessions and dig deep with us. And what you will also, I'd be remiss if I didn't mention, you're going to get a survey, a SurveyMonkey survey, when you get home in a day or two. Please fill it out. We take those very seriously. It helps us design next year's awesome program. Thanks so much for joining us in Bowling Green.